Hi, today we're going to talk about abuse of opioids. So the terminologies will be the same as the previous lectures on drug abuse. So opioids. So opium is the latex that is excreted when an incision is made on the green capsule of the poppy plant. So this is a picture of a poppy plant, just in case you have not seen a poppy plant before. So it's usually boiled. It's boiled to a sticky gum and chewed. It can be burned and inhaled, or you can also mix it with fermented liquids and then drink it. So opium is from the Greek word opos, which refers to juice or sap. So the main alkaloids that are extracted from opium are codeine, morphine, thebaine, and oripavine. So it's been cultivated. The opium poppy has been cultivated since 3400 BC in Mesopotamia, which is today Iraq, and it was introduced to the Orient by Arab traders and used mainly to treat dysentery, which is bloody diarrhea. In 1806, a pharmacist's assistant isolated a pure substance from opium, which he named morphine. So that was a little bit of history with regards to opium. So opium contains a mixture of alkaloids from poppy seed, and opiates are naturally occurring alkaloids such as morphine and codeine, while opioid is a broader term. It's a broader term that is used to describe all compounds that act as opioid receptor agonists. So this is a term that we're going to use a lot for this particular short talk. And narcotics, they are once used to describe opioids, but currently it is a legal term to describe drugs that are being abused. So narcotics, it's a term, it's a legal term. Okay, so most of the time we are going to refer to opioids. We're going to use the term opioid. So these are some of the categories of opioids, looking at its chemical structure. So we have what's known as phenanthrines, such as morphine, codeine, and oxycodone. You can see pretty much the structures, the presence of similar structures in all these three compounds. And then we have the benzomorphins, such as pentazocine, and then we have the phenylpiperidines, such as fentanyl and also fentanyl. And then we also have the diphenylheptanes, such as propoxyphene and also methadone. So as we can see from the above, there is a huge difference, there is a huge variation in the physicochemical properties of opioids, which will affect their pharmacokinetic attributes, mainly drug absorption and distribution. So due to the different structure in the compounds, due to the difference of the chemical structure of the compounds, so this will affect the pharmacokinetic characters of the drug, of the opioids, mainly drug absorption and distribution. And the pharmacokinetic features of an opioid, of course, are fundamental to the clinician. There are 4 most important dynamic factors that influence how fast the onset of the action of drug is, and the time to peak effect, and also the duration of action of any drug. So what are the 4 most important dynamic factors that influence how fast the onset of action of the drug, and the time to peak effect, and also the duration of action of any drug? So the 4 factors are the molecular size, the lipophilicity, the degree of protein binding, and also the level of ionization. So these are the 4 dynamic factors that will influence how fast we see the effect of the drug, and how long does it take in order to see a big effect of the drug, and what is the duration of action of any drug. So it will depend on these 4. This is a little quick review of the major opioids. So this is from the mostly pharmacokinetic perspective. So you look at the elimination half-life. We have alfentanil, buprenorphine, codeine, hydromorphone, fentanyl, methadone, morphine, oxycodone, pethidine, remifentanil, sufentanil. So when you look at the elimination half-life, it's pretty obvious that methadone and buprenorphine has the longest half-life. So it's going to take a longer time to be eliminated from the body. And in terms of clearance, remifentanil has the highest clearance, and then the volume of distribution is not that different from one drug to the other, so they are about the same. So for example, alfentanil is about 0.86 liters per kg. That's the volume of distribution. And in terms of protein binding, also not much difference between the drugs. And there is some amount of variation in terms of the lipophilicity, the distribution coefficient. So we can see that its codeine has a very low lipophilicity, whereas it's higher with fentanyl, and then it's a bit more with buprenorphine, and highest with sufentanil. And then we have the clinical onset of action. So the drug that has the fastest onset of action are alfentanil and also remifentanil, followed by sufentanil, fentanyl, and so for buprenorphine there is an asterisk here. So it mentions that the full effect, however, is only seen after 45 minutes. So you can see a little bit of effect after 2 to 5 minutes of taking the drug, but then the full effect is only seen after about an hour after the taking the drug. And the slowest onset of action is with codeine. So, and then we talk about active metabolites, and so we know that these drugs can be will be changed in the body to become either an active metabolite or an inactive metabolite. So with active metabolite we might see a prolonged effect of the drug, and you might see more unwanted effects of the drug if there is an active metabolite. So some of the opioids have no active metabolites, for example alfentanil, fentanyl, and methadone, and also remifentanil. but there are others that have active metabolites, such as codeine. So it has the codeine 6-glucuronide metabolite, and also morphine as its metabolite. And for morphine, we have morphine 3-glucuronide and also morphine 6-glucuronide. Okay, so for example, if you give an infusion, a prolonged infusion, you might see prolonged adverse effect of the drug or unwanted effect of the drug. For example, someone can be sedated for many days if you give a very prolonged infusion in the ICU or CCU, etc. And then with pethidine, you have the norpethidine. For sufentanil, you have desmethylsufentanil. And for oxycodone, it's oxymorphone and noroxycodone. And for hydromorphone, it's hydromorphone 3-glucuronide. So these are, take note, the drugs that have, the opioids that have active metabolites, as opposed to the drugs, the opioids that do not have active metabolites. So opioid receptors, the opioid receptors, they belong to a large superfamily of G-protein coupled receptors, the GPCRs, and we know that the GPCRs play an important role in signal transduction. So we can see the G-alpha part here in beta, gamma, and the binding of the agonist to the receptor, to the GPCR receptor, will lead to a signal transduction happening. So the opioid receptors are widely distributed in the brain and the spinal cord, and also it's expressed in various peripheral tissues, including vascular, cardiac, airway or lung, and also the gut, and also it's expressed, can be found in immune or inflammatory cells. Opiate receptors, they can be activated by both endogenous and exogenous opioids. And there are 4 main opioid receptors. So the first one is it's mu receptor. And then we have the delta receptor. And then we have the kappa receptor. And then we have the NOP receptor. So these receptors, they are found all over the brain and spinal cord, and also found in various tissues, including the blood vessel, in the heart, in the lung, and the airways, the bronchus, and in the gut, in the gastrointestinal system, and it's also found in even immune or inflammatory cells. So we're going to talk about a little bit more about the receptors in the next series. Okay. See you then. Bye.